Hello, and welcome to the ACE Hot Topic webinar titled Improving Oncology Patient and Program Outcomes with Cancer Rehabilitation. I am Jen Wood, Meetings and Administrative Manager for ACE. I have a few housekeeping items before we begin. This webinar is being recorded and it will be posted to the members only section of the ACE website. All attendees are muted for the entirety of this presentation. If you have any questions during the presentation, please submit them through the GoToWebinar toolbar question box. Dr. Waltke will be pausing periodically to answer any questions specific to the topic she just discussed during her presentation. She will also answer questions at the end. Please note that this presentation contains several graphic surgical slides. And it now gives me great pleasure to introduce today's webinar speaker, Dr. Leslie Waltke. Dr. Leslie Waltke is a physical therapist with a clinical mastery in oncology, rehabilitation, specializing in musculoskeletal, cardiopulmonary, and functional deficits related to cancer. She is the founder of Waltke Cancer Rehabilitation Academy, and a consultancy that educates and builds powerhouse cancer rehab programs around the world. A fierce advocate for improving cancer patient and cancer program outcomes, Dr. Waltke is an award-winning author, video creator, and sought-after educator and speaker, and we're so lucky to have her here today. We hope you enjoyed the webinar, and please take it away, Leslie.
Thanks, Jen. Good afternoon to everybody on the East Coast. Good morning to everybody on the West Coast, and happy lunchtime to those of us in the middle. My major goal today is to really give you a broad idea of what cancer rehabilitation looks like and how it can affect your patient outcomes, but also specifically your business program outcomes for your cancer programs. So on that note, just imagine this for your cancer program. Fewer emergency department visits, shorter length of hospital stays, fewer readmissions, decreased fall risk, improved chemotherapy delivery rate, fewer patient complaints, improved patient performance status, which is everything for medical oncologists, improved cancer outcomes, including quality of life, longer survival, as well as overall survival, and generally healthier cancer patients. Those are goals of all cancer programs, and those goals are significantly impacted by your friendly neighborhood physical therapist right down the hallway. So when you add a rehabilitation therapist to your cancer team, we all see the same patient differently. Whether you're med-onc, rad-onc, surgical oncology, we all see things a little bit differently. So what does a rehabilitation therapist see per se? Well, let's look at this pathology. So we have a 46-year-old male with stage 2B, diffuse large cell B-cell lymphoma. All right, he has, after meeting with his medical team, he's had surgical rotting of his left femur, adjuvant radiation to the left femur and quadriceps, and he has undergone the RCHOP protocol. So that's what the medical oncology team sees. Now, this is what the rehabilitation team will see. This is Maurice. So he has undergone a massive rotting to his left thigh. He did not know he had lymphoma until his left femur shattered. So he was petrified to weight bear on this leg again. Then it was radiated. So now the soft tissues, the skin, the quadriceps were hard as a rock. He barely had any knee flexion because the soft tissues were so tight. So he couldn't walk well. He couldn't weight bear well. Then he was significantly fatigued from the chemotherapy. And on top of it, the chemotherapy caused a lot of neuropathy for him. So now he's numb basically from the knees down. So from my perspective, that's the stuff that I see. And my job on his cancer team is to minimize his fatigue, get him walking normally again, get him back to work, and get him back to normal function. So that's what we see with this particular pathology. Now, another pathology report, 31-year-old female with left popliteal fossa osteosarcoma. So she has had or will undergo a surgical prosthetic replacement and then will have chemotherapy. So that's one side of the coin. And again, here's that surgical slide that Jen warned you about. This is one of the most amazing surgeries I've ever seen. So removed the bottom of the femur, top of the tibia, replaced it with this prosthetic. And now it is my job to do multiple things. This is Emily. So this is how I see this particular patient. Of course, she lives on the second floor of her apartment, has difficulty weight bearing, has difficulty with moving that knee, is still on crutches, can't get up and down a flight of stairs. And on top of that, she's now going to undergo chemotherapy, which is going to cause, the typical sequela of fatigue, weakness, and loss of function. So I have to find a way to get her back to normal functioning, as well as keep her strong and fit cardiopulmonarily and musculoskeletally during her chemotherapy. So we just see things differently. Another quick thing I want to do before we get into the meat of this is talk about what cancer rehab isn't. There's a lot of, not necessarily myths, but just there's a lot of thought that it's very contained. And let me show you some of those things here. If I had a nickel for every time somebody said to me, when I say I'm a cancer rehab therapist, oh, you treat lymphedema. And yes, I do, but I will very strongly state that the primary role of a cancer rehab therapist is not to treat lymphedema, but the primary role of a cancer rehab therapist is to treat the musculoskeletal, integumentary, and physiological and functional problems related to cancer and cancer treatment. So when you look at that list, the top complaints of cancer patients are typically these 5. Fatigue isn't the most common and most distressing patient complaint. Pain is number 2, and weakness is number 3. Yes, I treat lymphedema, but on a frequency of symptom list, it's probably down between 15 and 20 of the most common symptoms that we see. So it's critical that anybody developing a cancer rehab program kind of gets out of that lymphedema thinking. I equate it to building a state-of-the-art orthopedic rehabilitation center and only treating left ankles. I mean, you just wouldn't do that. So I don't want that to happen with our cancer patients. Another thing that a lot of cancer programs make mistakes is that they just send the patient to the rehab therapist. The rehab therapist sees them one or two times post-operatively, and then they're done with the patient. That is problematic for 2 reasons. Number 1, in oncology patients, scar tissue development, because of the type of surgery, and radiation fibrosis often develop weeks or months after the end of the actual treatment. So we can't help that patient if they're not on our caseload anymore. So they may present with no pain or no dysfunction post-surgically or post-radiation, but weeks or months later, they start to develop problems. Secondly, if somebody has surgery, which I think 50% of cancer patients do, they will typically be followed up with radiation and or chemotherapy, and each of those modalities themselves will create their own musculoskeletal, cardiopulmonary, and functional deficits. So again, I train my therapists that they need to think of their care for this patient, not just as post-operative, not just one visit, but through the entire treatment trajectory for this particular patient, whether it's weeks, months, or sometimes a year or more. Here is a perfect example of how I mentioned earlier how scar tissue and radiation fibrosis are a significant issue in cancer surgeries. So here is a patient who is literally about 30 seconds post-mastectomy. So you're looking at the left pectoralis major and the serratus anterior underneath here. Now this is that same chest wall a year later, okay? So this is all scar tissue development. It's a normal physiological process. I can't stop it, the patient can't stop it, the surgeon can't stop it, it happens. But because this patient was working in rehabilitation, she was, during this scar tissue maturation phase, during the radiation fibrosis phase, stretching, strengthening. We were doing manual therapy work to keep her skin and the connective tissues loose and long, so as that scar tissue process happened, it doesn't cause her pain or doesn't cause any limitation in function or mobility. So it's there, but it doesn't bother her. If this patient wasn't moving during this process is when you start to see patients a year or 2 later still complaining of tightness and restriction in their upper quarter or wherever their surgical area was. I believe it was 2016 that ASCO published a report on the cancer survivors in this country, and one of their statistics was up to 40%, 40% of our cancer survivors in this country are still complaining of pain. And most likely 80 to 90% of that pain is scar tissue or fibrosis or weakness related that any physical therapist could fix pretty quickly. So that's really unfortunate. Another soapbox issue of mine is that rehabilitation should not just be for your patients with breast cancer. All right. Any patient that's exposed to surgery, chemotherapy, or radiation is probably going to experience, to some level, some fatigue, pain, and weakness, or loss that needs to be addressed. So it does not matter what kind of cancer they have. How that treatment plan or best practice looks, depending on whether it's lung cancer or breast cancer, might look different, but every patient deserves access to good quality cancer rehab, regardless of what kind of cancer they have. So again, a lot of programs focus on breast cancer, and again, you're missing a good part of your population when you do that. So just some clinical slides. This is Ruby with lung cancer. This is Eileen with endometrial cancer. Whoops. This is Ray with gallbladder cancer, and this is Maritza with ovarian cancer. So we see everybody in our clinic because, again, they all struggle with the same symptoms. And finally, we're getting better at this, but the NCCN actually recommends that patients be referred to rehabilitation at the time peri-diagnosis. And we should not be waiting until the patient has a problem to get them their cancer rehab referral. Because the evidence is very clear that with rehabilitation, we can either delay or minimize or prevent those problems from happening if we can get on board right away. So if we can get a patient exercising before their chemotherapy starts, if we can get them exercising immediately after their surgery, if we can get them moving immediately after their radiation, they don't develop the problems than if we wait too long. All right, so that's your introduction to our topics today. What we're going to be going over is what cancer rehab isn't and what it is, which we've just kind of done. Again, benefits to the patients, but also what it is that we do. So I'm going to do a quick review of what does a physical therapist do around the time of surgery, what do we do around chemotherapy, what do we do around radiation, because people just don't know what we do. And then, of course, the benefits to the cancer program and your health system, because they are incredible. And then we will also go over the steps to building or growing your cancer rehab program. So I am the cancer rehabilitation coordinator for Aurora Healthcare. We have in the Northern Wisconsin division, which is my responsibility system-wide, we have I think we have OTs, PTs, and speech pathologists, inpatient and outpatient, at 15 of our hospitals. And we have 27 outpatient clinics throughout the state of Wisconsin that treat patients with cancer. So we are really big. Here is my contact information. I'm very easy to get a hold of if you need something, want to talk or have questions. I'm certainly available by phone or email. And then I want to point out to you really quickly a completely free, no obligation resource, typically for patients, but therapists and physicians and nurses love it as well. It's called the Recovery Room, and it's a video series that I have. And it's, again, directed towards patients and cancer patients and survivors, but they're videos that are free on YouTube and Facebook called the Recovery Room. And they are short. They're typically anywhere from 2 to 6 minutes long. They're positive, they're medically accurate, and they're intended to educate cancer patients and survivors on some topic relating to cancer rehabilitation. So that's fantastic, so check that out. All right, so we've talked about what cancer rehab isn't. Let's spend some time connecting, you know, how do we connect cancer and chemotherapy, surgery, and radiation to physical therapy, occupational therapy, and speech pathology? Well, when you talk about cancer sucks, you know, people talk about surgery, chemo, radiation, but when you start talking with patients, the things that they start to complain of or are talking about are fatigue, pain, weakness, numbness and tingling, very common, limited mobility, limited motion, balance problems, and difficulty walking. Very, very common problems in the cancer patient and cancer survivor cohort. And this is what rehabilitation therapists do for a living. This is what we treat. So cancer diagnosis leads to medical management of one or all or 4 of these. And then medical management then leads to this side effect profile, and that's where the rehabilitation therapists come in. So we've talked about fatigue, pain, weakness, limited range of motion, scarring already, stiffness, but we also deal with edemas, neuropathies, bone loss, muscle loss. In our patients with breast cancer, they typically gain weight under chemotherapy, which increases their risk for recurrence, increases their risk of a whole bunch of other problems, including dying of heart disease, and it actually increases their risk of lymphedema as well. So patients who are in rehabilitation tend not to gain as much weight. We also know that patients who get cachexia, so our folks with advanced lung cancer, our GI cancers, our late-stage cancer patients, they start to lose too much weight, And again, patients that have a too low of a BMI, again, their overall survival is impacted. And the studies strongly suggest that patients who exercise in a cachexic state actually can build muscle mass and kind of reset or slow down that protein degradation process. Balance issues are huge. And again, depending on the type of surgery or treatment, incontinence, swallowing, cognition, or sexual issues may also be a part of this patient's side effect profile. So if I had to put cancer rehab on one slide, it would be from diagnosis to survivorship, that entire span, the evaluation and treatment of musculoskeletal, cardiopulmonary, and functional impairments. That's our wheelhouse. That's what we do. That's what we have time to do. And that's what we get paid to do. So this is reimbursable medical care. So we know that medical oncologists, surgeons and radiation oncologists are very busy. They don't get a lot of time. The research proves that they do not have time to sit down and talk about exercise programs, pain, and all those sorts of things. They don't even make the list. So not only do we have the time, it's reimbursable time from our perspective and from a business perspective. So it's really good for both the program and the patient. So as I've mentioned, who needs a cancer rehab consult is really anybody who's going to be exposed to surgery, chemotherapy, or radiation. So we like to see 100% of cancer patients and then do a consult, just like a radiation oncologist would or a medical oncologist would. Not every person that comes to see us is going to get rehab, but we can look at them, we can assess them, and determine, no, you don't need rehab, but you know what, you're going to in 3 months, so I need you to do this, this, and this now, follow up with me in 3 months. Or you look great, call me in 6 months. Or you know what, you're a train wreck, you've got a lot going on, you have a lot of pain, you have a lot of limited mobility, you're going to be starting chemotherapy, let's have you come back later this week. So that's our job on our initial consultation, to determine if they need rehabilitation, and if they do, how much and when. So now let's talk about benefits to the cancer rehab program, and we kind of opened with this, but again, these are all evidence-based. So patients with cancer that are working with a rehabilitation therapist have fewer emergency department visits, they get out of the hospital faster, they come back to the hospital less often, they don't fall as often, but they actually tend to stay on their chemotherapy cycle, whether it's every 14 days or every 21 days, and that has been shown to improve overall survival by keeping people on their specific dateline routine. Patients have better performance status when they're working regularly with a rehab therapist. And again, performance status, body mass index, and ejection fraction, which is EF, those are the cornerstones for a medical oncologist in how much or what type of treatment this patient can get, and that treatment will determine overall survival. So by making our patients healthier, more active, safer, and stronger, we are allowing them to get maximized cancer treatment to improve overall survival. And then certainly, again, rehabilitation is evidence-based, reimbursed programming. So it actually increases revenue. So I will often tell administrators, we can actually save you money and make you money at the same time. Now, benefits to patients, which are huge. Again, this is all evidence-based. We know for a fact that quality of life goes up. We know that patients exercising and in rehabilitation programs will live longer if they have stage 4 disease. Most of that, again, is because of strength. Cardiopulmonary function leads to better performance status, more treatment. And then there is strong evidence that the cancer survivors who exercise compared to those who don't have better overall survival. We don't know why that is. We are looking at it, but the evidence is quite clear. There's also evidence that for colon cancer survivors, breast cancer survivors, and prostate cancer survivors, that exercise in survivorship actually decreases the risk of recurrence. Now that is really powerful stuff. If it doesn't come up later, I would tell you that our folks in cancer rehab, we do not have a compliance problem. What we do is patients feel better instantly after we see them. Exercise typically makes them feel good. So once we get people moving, it's just a great thing. They will have maximized cardiopulmonary function. They're going to either maintain or improve their body mass index. Sometimes this can take weeks, months, or years. So they stay stronger during treatment, and they recover much more quickly when treatment is done. So they lose less, and they recover much more quickly. So now the next slides are going to be very text heavy, and I'm not going to read them all, but I know that this webinar will be available to you afterwards on the ACE website, so you can go through and then actually pause these and read it. But as I've mentioned, rehab increases quality of life, length of life, and can impact overall survival and recurrence. Cancer rehab is a standard of both the COC and the NAPBC. And as I mentioned, the NCCN recommends that rehabilitation begin at cancer diagnosis. Another thing I want to point out on its own slide is the only evidence-based treatment for cancer-related fatigue is exercise. And again, studies suggest that only about 20% of medical oncologists bring up exercise in their consults with their patients, the patient visits. Again, they just don't have time. And if that does come up, they don't typically know what the guidelines are, and they can't spend time talking about, oh, my back hurts, oh, my leg hurts, so I don't have anywhere to go, and answering the 1,000 questions that people have when you ask them to start exercising. But again, we rehabilitation therapists have the time to do that, and we get reimbursed for it. So that, again, that's our wheelhouse. So again, very text heavy, and I do have all of the references listed for you. So I'm going to just click through those really quick so you can look at those on the replay of the webinar. But in some types of cancers, like head and neck, prostate, GI, lung cancers, we do want to see people preoperatively because we can improve postoperative outcome, whether it's getting out of the hospital faster, decreased incontinence, better swallowing. We want to see all people postoperatively for a consult. And again, people in neoadjuvant chemotherapy often get missed with a rehab consult. Again, there's no reason to wait. We know that exercise impacts function and fatigue, so even patients in neoadjuvant chemotherapy should get in to see us, certainly during chemotherapy. And again, depending on the type of cancer, some of our patients will be seen during or prior to radiation, some will be after. And then certainly we have a role in survivorship, advanced disease and end of life, which I will talk about in some slides coming down a little bit. All right, and again, from a exercise perspective, this data, again, is very clear. It's been reproduced multiple times, and it is acknowledged by the American Cancer Society, the NCCN, the ACSM, that 150 minutes is kind of the target that we want most of our patients to be hitting. That's approximately 25 to 30 minutes, 5 to 6 days a week. And again, with a rehab therapist on the team, most patients, regardless of whether they're 30 years old and healthy or 85-year-olds and unhealthy, that we can break that down and help patients find a way to get that volume of exercise or activity in their daily routine. And then here are those references for you. And then Jen, did you want to check to see if anybody has any questions so far? Okay.
Yep. Sorry about that, Leslie. I couldn't get off mute. So we had one question that came in. How do you go about educating radiation and medical oncologists about the need for and benefits from rehab, especially getting referrals at or soon after diagnosis?
Yep. And that's part of, and we'll address that more specifically towards the end, because you can have the greatest cancer rehab program on the planet, but if you can't get your docs to send people to you, it's kind of a moot point. So what we suggest is, and I'll get more into this later, but is certainly doing in-services for your cancer, for your medical oncology, radiation oncology, and surgical oncology teams independently, because the benefits of rehab for each of those 3 different professions is very different. So we target this is what it can do for surgery, this is what it can do for radiation, and then start making the patients very happy. Patients go back and talk to them, and it starts that kind of pushing that flywheel of getting patients and physicians to refer. It's also a really good idea to wrap in the cancer nurse navigator if you have one, because they spend more time with that patient and they can see benefit for benefit of what rehabilitation can do. I also recommend strongly that rehabilitation therapy, or excuse me, medical oncology providers actually come over to the rehab department to just see where their patients are going, what they're doing, meet the therapists face to face. And then I recommend that our therapists spend time in the clinic with the med-onc, rad-onc, and surgical oncology teams, whether it's going into the surgery, hanging out in the clinic, So again, you guys get to know each other, and then slowly we incorporate rehabilitation into the comprehensive team, including MDCCs, MDCs, and administrative meetings. So thank you for that question.
And we have one more, Leslie.
Yep.
Do you consider your consult visit a billed evaluation?
Yes, it is. The rehabilitation or consult in our terms is called an initial evaluation. You can get a patient to PT/OT or speech pathology with a referral from a nurse practitioner, an MD. And under that evaluation, that's our consult, that is billable. And 100% of insurance companies will always cover a evaluation or consult. Okay, and then insurance companies vary from, as we all know, some are great, some are not so great, some have great coverage, some have average coverage for rehabilitation. But again, our therapists will know going in what type of coverage this person has for their rehab services, and then they can discuss with the patient. This is what I want for you over the next 12 months. Here's what your insurance will cover. How should we? So you team up with the patient and the therapist. How do we go about best managing your rehabilitation dollars? And I will also say that by the time patients get to us and they've had surgery and or chemotherapy and or radiation, that their copays and deductibles are pretty much gone. So often there is no charge at all for really good quality cancer rehab services, which is great. All right. All right, so best practice then on one slide is we want our patients to get exercising immediately, every type of cancer, every person, every body type, every age. So I joke that I want my pathologist to get patients moving. That's how early we should be working together to initiate exercise and activity. We will see people preoperatively or postoperatively or both. We will have rehabilitation oversight during and after chemotherapy, rehabilitation and oversight during and after radiation. We will see people in survivorship on an as-needed basis, and if cancer does impact the length of their life, we will intervene there as well, again, on an as-needed basis. So just to break it down again, what I want to do is show you what we do from for a surgical patient, a chemotherapy patient, and a radiation patient really quickly. So again, local treatments include surgery and radiation. Systemic treatments include chemotherapy, hormonal therapy, biological therapies, now the immune therapies. But here's where the rehab piece comes in. These are the side effects of those local and systemic treatments. And rehabilitation can either minimize, eliminate, or prevent everything on this screen, with the exception of, where is it? Neuropathy. Okay. There is some evidence that exercise minimizes the amount of neuropathy people get, but I don't think it's a lot. But what happens is people get neuropathy and then they stop moving. They sit down, it hurts to move, so they just stop. So we have to find ways for people to continue to move, even in the presence of sensory neuropathy, whether it's getting them in a pool, sitting them on a bicycle, having them put on an extra pair of socks when they walk, to keep them strong. I'll tell patients you can either be numb and tingly and weak, or you can be numb and tingly and strong. But otherwise, everything on these lists, again, can be prevented, minimized, or eliminated with rehabilitation, either during or after cancer treatment. So again, if I put cancer rehab on one slide, this would be it. We treat musculoskeletal, cardiopulmonary, and movement and functional problems before, during, and after treatment. So I will, again, be in touch with my patient on an as-needed basis for their entire cancer care continuum. So again, I want to give you a quick touch of what does cancer surgery, rehabilitation, radiation-related rehab, and chemotherapy-related rehab look like. So post-surgically, it's going to be very similar to somebody who's had a back surgery, knee surgery, shoulder surgery. Our job for post-cancer surgery is to eliminate pain, restore flexibility, treat tissue tightness, restore range of motion, and eliminate weakness. So get people back to who they were prior to their surgery. And again, because cancer surgeons are basically taking out tissue, they're not fixing something like a back surgeon or a shoulder surgeon or a knee surgeon. So patients don't always get back to 100%. But with rare exception, cancer patients after surgery should get back to 100% of function. And if they don't, the reason is typically because of scarring or radiation fibrosis. So we really can work that and massively improve outcomes. So our job then is to eliminate pain, restore preoperative function. If you have a lung cancer patient or a breast cancer patient that has to start radiation in a couple weeks, it's our job to make sure that patient's ready to do that when the time comes from a range of motion position. And again, there is strong evidence that for people who've had breast cancer surgery, axillary dissection, that physical therapy can reduce the risk of lymphedema significantly over their baseline, which is great news. So again, I showed you this picture already. This is the patient 30 seconds post-mastectomy. And again, this is the scar tissue. So from a post-operative rehab perspective, the things that are on a typical treatment plan will be therapeutic exercise, obviously, but also a lot of stretching and a lot of hands-on manual therapy. So from a post-operative standpoint, often patients will lose a lot of skin. So you have to now have superior edge, inferior edge. You have to pull those two pieces together and sew that closed. So that can limit mobility at the chest wall. So again, stretching, 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 stretching. We are very cautious to not make patients come into the clinic more than they need to. We know visit burden in oncology is huge. So we try to either combine visits with the oncology team or just minimize and get people doing as much as they can at home to keep them from coming back into the hospital or into the clinic. So stretching, stretching, stretching. We will do a lot of strengthening stuff. So again, manual therapy, stretching, strengthening, very standard stuff post-surgically. Now, from a chemotherapy perspective, our job again is to maximize cardiopulmonary health and musculoskeletal strength. Again, we don't know what causes cancer-related fatigue. We don't know why exercise helps, but it does. And the study suggests that there is usually a lot of musculoskeletal muscle loss in the large muscle groups, including the core, hamstrings, quads, and glutes. So regardless of the type of chemotherapy, regardless of the type of cancer, we will often have people strengthening arms and core and legs. Again, targeting that 150 minutes per week of exercise to decrease fatigue, minimize pain, keep people on their treatment schedules, decrease the amount of muscle loss and bone loss they have. Again, either maintain their body mass index, keep it from getting bigger or smaller. And again, another really big one is helping patients maintain their ejection fraction above 50%, which again allows them to get more of their chemotherapy. And again, the data from the 70s, the nursing data, has shown for a long time that exercise minimizes nausea, decreases anxiety and depression, which we all know is a huge problem in the cancer population. And what exercise does, and again, we don't have a compliance problem. This stuff feels good. An easy walk around the house, an easy walk to the mailbox, an easy walk around the block makes people feel better. And again, just some clinical slides. This is Kathy with breast cancer. This is Mary with fallopian tube cancer. Again, 82-year-old female, independent, living by herself. But like any 82-year-old, she's marginally independent. So now she's getting thrown at chemotherapy and surgery at her. So she was very concerned that she was going to not be independent anymore. And when I asked her what her goals were, she said very clearly, I do not want to move in with my children. So again, developed a walking program for her. She flew through surgery, had no problems whatsoever. So I didn't need to treat that at all. So we got her on the leg press machine, showed her some squats and stair exercises to do at home. And she was able to stay strong enough during her chemo that she didn't require any hospitalization. She did not need to move and lost very little function. And this is good old Larry. Larry has really serious neuropathy. He's got lung cancer and metastatic lung cancer in his brain. So again, from a chemotherapy perspective, we can't necessarily directly impact the neuropathy that people have because it's sensory, but we can minimize the motor functional loss that people do have because they're not moving normally or they're stuck on the couch. So again, balance activities, flexibility activities, proprioceptive activities, and a lot of strengthening and movement activities. And again, then just good old cardiopulmonary exercise, whether it's on a treadmill, on a bicycle, outside, inside, it doesn't matter as long as we get people moving throughout their chemotherapy. And this is my poster child for no matter how low somebody's counts go, whether it's red count, white count, or platelets, exercise has been shown to be safe in the literature. That being said, though, is if somebody has an absolute neutrophil count, like this young woman here who's getting treated for leukemia, she can still exercise, but she needs to be protected from infection, so glove, gown, and mask, right? But exercise is safe with low counts. So we've worked with our inpatient teams now and our medical oncologists, and our med-oncs will now say to our patients, you have no right to refuse when the PT comes into your room. So we've worked with the nurses and the doctors to get everybody on the same page. So patient compliance again goes way up. They get out of the hospital faster. They get a lot less sick. And one of my favorite quotes, if you have to be bald, we want you bald, smiling and sweating. So another quick tip to go back to the question we got before is how do you get doctors to refer, is if I know that I have a meeting coming up with a specific doctor, I'll try to get his patients and take pictures of those specific patients, smiling and sweating and doing the things that everybody just thinks wouldn't be possible. People don't, you just can't imagine somebody who doesn't feel well exercising, but they can, they do, they sweat, they've got a towel around their shoulders, and they do feel so much better. So it's a great tool for marketing. Now from the radiation side of things, we again will treat with manual therapy, hands-on, because again, radiation is known to cause tissue fibrosis, tissue hardening, tissue thickening, but also cardiopulmonary exercise and strengthening to minimize the fatigue that people have with the radiation. So the purpose of rehabilitation for folks in or after radiation is to get ready for the radiation position, if we need to, minimize or eliminate fatigue, and then restore range of motion, flexibility, tissue strength and function if there is any radiation fibrosis present months down the road. So this is Jeff. Jeff had a oral cancer that was radiated and he was treated at a competing cancer center. So he did not get rehabilitation. And I want to point out, look at the atrophy in his right shoulder girdle. Now, what I said before, we don't have to rehabilitate what the patient doesn't lose. This is a perfect example. If he had just been doing simple strengthening stuff, range of motion at the neck, he would not have lost. He was still having trouble swallowing, not because of the internal mechanisms, but because the skin around his neck was so tight and painful. Had he been doing gentle exercise, gentle range of motion during his radiation, this would not have happened. And it's going to take him months now of hard work to regain that. For somebody who's getting radiation directly to the brain, and this is Arturo, who has a glioblastoma, rehab can become more dynamic than just aerobic exercise. So he was having proprioceptive problems, so balance and walking problems because of the tumor's effects on the brain. So again, stepping into that realm. And then here is the left axilla of a gentleman who has lung cancer. He had a recurrence to his left axilla. So rarely do you get to see radiation fibrosis, but this is classic example. So you've got the vascular petechiae. You can see the leathery tightness, thickness here. So he was having a significant amount of pain, significant edema at the arm, and limited mobility, pain, loss of function. And this was going on for 3 years. And then finally, somebody got him into rehab. We were able to eliminate his pain within 2 weeks of just stretching and some manual therapy to this area. Swelling in the arm went completely away. And his pain came down from an 8 to like a 1. And his range of motion went from, minimal to almost normal. We also worked on his fatigue level, which 3 years after his lung cancer treatment was still moderate. And again, for somebody who's got a really poor 5-year outcome, having those first 3 years wasted by being in pain, wasted by being fatigued, it's just really unfortunate because we made all of that go away within 6 weeks of easy rehabilitation 1 time a week. And he was so happy. Here is radiation to a right post-mastectomy chest wall. So we've already talked about how the loss of tissue can cause range of motion problems. Radiation tightness and thickness, when this starts to shrink and get tight over the next months, you can see again how mobility can be affected at the chest wall. But again, patient now with rehabilitation has full range of motion. We're going to teach her to keep it there so she doesn't lose it. And again, I mentioned we will do a lot of, here's somebody who's probably 1 or 2 years post radiation. So the skin gets really thick, really tight. You can see how tight the axilla is. That causes pain. That causes limitation in mobility. Pain and limited mobility cause less use and more weakness. So again, we can get our hands on here even years later and improve outcomes for these patients. And then once we get into survivorship, again, some patients just step out and they're absolutely fine. We just ask them to check in with us once every couple of months or call us if they have any problems. But the things that we keep our eye on from a rehab perspective is watching bone density and making sure they're on an appropriate exercise program to combat that, especially if they're on an aromatase inhibitor. If there is remaining pain and fatigue, which there often is after cancer treatment, we keep them on and watch them to make sure that that eventually does go away. We combat muscle weakness, help patients with weight management, either gaining weight, putting it back on, or if they've gained weight, to get it off. And again, continuing to help and support patients in that 150 minutes per week of cardiopulmonary and strength exercise. The studies suggest that patients do a really good job of exercising during their chemotherapy and their radiation, but once they step out of cancer treatment, typically after 3 months, they stop exercising. So we have to work on finding ways to keep them going for a lifetime, not just during treatment. And then again, in survivorship, we will see radiation fibrosis pop up if it does. So here's June, who has lymphoma, continuing to exercise. You can see her hair starting to grow back on the top of her head. But in survivorship, again, we work on a lot of functional activities. So June was 72 years old, and when I say, what do you typically do? She's like, I'm retired. I go out to lunch. I go out to dinner. So finding other things, what's difficult for you? What hurts? What's problematic? And she said, doing curves. My legs are so weak that I'm afraid I'm going to fall. So we can work on those things specifically to help our patients. And again, these are all my patients. I actually run a triathlon training program for female cancer survivors in survivorship. So this is how we want our cancer patients to look. And this is possible. Some of these people literally just finished treatment within 3 to 4 weeks before starting this program. So we can shift the thinking from this is going to be awful to yes, this is going to be awful, but let's help you through, make you stronger, keep you healthy. And my job actually on here, this is my old hair. My job on race day is to actually hug all these people coming across the finish line. It's absolutely fantastic. All right, and then if we have a patient who is going to lose their life to cancer, we will, again, assistance as needed. We don't go where we don't belong, and we want to be there when we need to be there. Is maintaining functional strength is huge in the last weeks or months of life. I will tell patients that their quad strength, being able to stand up from a bed and pivot to a chair, or standing up from a bed or getting to and from a bathroom, which is 10 feet away, that makes the difference between going home and getting stuck somewhere. So the stronger they can stay, even if it's standing and turning, they have more options on where they go, where they live, and where they die. So safety and mobility, getting people walkers, making sure they don't fall, safe transfers, getting them in and out of bed, positioning, and then actually helping the family as well, again, to make sure the patient stays as functional as possible for as long as possible and as safe as possible. So here's some of my folks with stage 4 disease. This is Roger with metastatic colon cancer, sitting on the bike, keeping his heart and lungs up. Another thing we see with stage 4 patients is a lot of spine mets, obviously. So there are ways, and spine mets can hurt. Spine mets can limit activity. So there are ways for us to safely strengthen and decrease pain in those scenarios. So Joe has metastatic prostate cancer all up and down his lumbar spine and his sacrum. So here he's actually an ICU nurse. Here he's attached to a belt, and he's pulling forwards and backwards about 60 pounds. And that will stabilize his core, strengthen his spine without bending it or putting him at increased risk of fracture or pain. And by that strengthening, again, we can improve function, decrease pain, and improve his quality of life. This is Mr. Talley. Again, it's hard to see here, but he's so skinny. Again, one of those people he had advanced lung cancer, getting skinnier and skinnier. So again, using that belt to weighted exercise, balance exercise, strength exercise, giving him some stair exercises, just some simple squats against the wall, push-ups against the wall, can help him maintain his muscle mass, keep him strong as possible for as long as possible. And then again, functional activities. This is Raymond, who has advanced lung cancer. He, of course, lives on the second floor as well, and was caring for his sister with Alzheimer's. So he needed time and function to be able to find somebody to care for his sister for when he wasn't around. So again, a lot of functional activity specific to what that particular patient needs. And again, this is my poster child for no matter how close somebody is to death, exercise has been shown to be safe. Again, as long as you protect the patient from falling, infection risk, or bleeding. So this woman literally died about 1.5 to 2 weeks after this photograph was taken. So even at end of life, if possible, and if the patient wants to, and if it's appropriate, exercise and rehabilitation can improve quality of life even in the last weeks, and it has been shown to be safe. All right, so now let's take a few minutes to just talk about either growing your cancer rehab program if you have one, or starting a cancer rehab program. So again, as I mentioned earlier, rehab is a standard for the NAPBC and the COC, and the NCCN states that it should start at diagnosis. So what I suggest to cancer programs is start with your analysis phase. What do you have now? Who's doing it, and how much are you seeing? Where do you, again, if you're a small program, whether it's one site or whether you're a large multi-hospital system, so where do you need therapists? Where's your volumes? What types of cancers are you seeing and how much? That's going to determine where you may put a cancer rehab therapist and what type of training they may get. As far as I have therapists at my tertiary center that all they do all day long is just see people with lung cancer. My folks that are out in the very rural settings, they have to know how to treat every type of cancer. So their education might be a little bit different. So then we're going to get into teaching the rehabilitation staff and training them to do this, as well as the oncology staff. The teaching and the training typically is done through continuing education. So what's nice is the therapists will get continuing education credits for it, which is a kind of a double whammy in goodness. And then also, the cancer program can actually, if they choose to, some actually bill the therapists for that training, some of them don't. Totally up to your program. But we have to teach and train the rehab staff as well as the oncology staff. So both sides of the quarter know what's going on. I call it the rehab gap. Cancer docs and nurses typically don't know what rehab people do. Rehab people typically don't know enough about oncology. So our patients are falling through the middle of this gap. So that teaching and training is to pull those two sides together to make sure that everybody knows what everybody does, and then incorporate that programming. So then we start building programs, and that's like creating treatment guidelines and best practices for your patients with breast cancer rehab. And again, whether it's GI cancers, lung cancers, head and necks, whatever you see most often, leukemias, lymphomas, bone marrow transplants, whatever your system needs is where you build your programs around. And then again, as I mentioned, then slowly integrating rehabilitation into cancer meetings. So my therapists go to all the MDCs, they go to all the multidisciplinary cancer conferences, again, whether it's disease specific or general. And then we also go to all the NAPBC, COC meetings as well. And then ultimately, this isn't just starting, you have to be in it for the long haul to make sure that this program is sustainable, even if a therapist leaves, or even if a new medical oncologist leaves or a new one comes in. So measuring, using what metrics do you need to make sure that your patients are happy? What metrics do you need to make sure that you're actually getting the outcomes that you want? And then continually looking at efficiency. Are we doing this best practice for the cancer center? Are we doing it best practice for the patients? And then always just checking patient satisfaction and patient outcomes. Are they in less pain? Do they have less fatigue? And those are things that we on the rehabilitation end can do fairly easily with our outcome tools. So the nice thing, is my favorite thing about starting a cancer rehab program is it doesn't require any new capital. The rehabilitation program department is already there. We don't need any new fancy equipment. We don't need a new anything. So rarely does it require a new tool or a new piece of machinery. Typically, you can use existing rehabilitation staff. So rarely do you ever need to hire somebody unless your volumes go through the roof. But typically, the rehab staff there can be trained to take on this volume. And again, the investment of dollars will be in educating and training the rehabilitation staff. And then again, you'll have to do in-services to the surgical, medical, and radiation oncology teams. So everybody, again, is on the same page. Mark, I see Mark Glenis has a question. What's up, Mark? My friend, the PT.
I can go ahead and read Mark's question. He has a challenge that he's faced many times is getting patients to maintain an exercise program after finishing PT. How do you motivate patients to continue, and do you follow up with them from time to time?
Absolutely, following up is absolutely critical because that's that piece of I'm losing my word, accountability. So again, I tell my therapist to make it so easy that the patient can't fail. Typically make it goal-oriented, so patients have something to look forward to. So in 3 weeks, I want you to be able to do 20 of these versus 10 of these. In 6 weeks, I want you to be able to walk a 5K. So we know that goal-oriented programs that are medically supported, so do keep in contact with the patient. Let them know that you're there, whether it's by telephone or by visit, so they feel supported. And that's the Team Phoenix program that I was showing you earlier. We have learned from that when patients feel they're medically supported, when they have a plan that's specific, a prescription for them, they know exactly what they need to do every day, and that it's goal-oriented, their compliance goes from, I think the typical cancer survivor, 17% of them exercise routinely. Our cancer survivors are up around 70% of them are continuing to hit that marker. So again, a lot of that's just talent and setting out your patient for a success with a prescription and a goal and a plan. It's a great question, Mark. Thanks. All right, so to wrap up really quick, couple of key points. Referral for consult should be based on whether the patient's going to have surgery, chemo, or radiation. Don't wait for problems to happen. Rehabilitation improves quality of life, length of life, and overall survival. It's important for everyone, not just people who have advanced disease. So even stage 0 people will have musculoskeletal problems. So they deserve care. And again, survivorship is much too late to start these people. They need to be started right away. And again, cancer rehabilitation is evidence-based and insurance reimbursed. So to finish out, take a look at your patient. This one on the screen here, she's a 47-year-old female with a stage 2B right breast cancer, triple negative. So she has already completed neoadjuvantly ACT. She's had a right modified radical, a left prophylactic with sentinel lymph node biopsy. So she's had bilateral expanders now in that are overexpanded, and she is 6 weeks post radiation. So that is getting everything possible through. I mean, that's the all-inclusive package. That's everything. Now, without rehabilitation, this person would probably be in pain. They would be fatigued. They may not have good range of motion. They may be at significant risk for lymphedema. They may have problems with mobility due to their tissue expanders and have a lot of pain from the radiation, as well as, again, fatigue. But here is literally this patient. This is Sarah. Her hair, this is 6 weeks post-cancer treatment. Now, yes, she could ski before her cancer treatment. But again, by maintaining quad strength, arm strength, physical strength, keeping her active and moving during her reconstruction, during her chemo, during her radiation, and after, that she was able to very quickly return to her normal function. So take-home points, cancer rehab has been shown to improve quality of life, lengthen life, and save lives. So we have to stop treating these people like they're going to break. I often find, and again, somebody alluded to it in their question, is we often find doctors and nurses say, oh, you know, that's going to be too hard, it's going to be too much. You know, family members, oh, don't do that, I'll get it. And that just sets up a insecurity and a vulnerability perspective for the patient, where we say, if we flip that and say, listen, this is going to be yucky, but during the whole thing, we're going to train you to take on chemo, surgery, and radiation. We're going to keep you strong. We're going to keep you healthy, and you're not going to break. So those are really, really key ways to flip your medical oncology team looking at stuff as well as your patient. So thank you so much for your time. I really appreciate you being here. I know that the world is kind of crazy right now, and I'm sure you've got a million things going on with the continuing changes from the pandemic day to day. So I appreciate your time very much. Again, please, I'm very easy to get a hold of. I would love to talk with you one-on-one. So please email or call anytime. Thank you. And Jen, are there any other questions?
I think you gave us a lot to think about, and thank you so much for this fantastic and personalized presentation. We currently do not have any questions, but why don't you give your email address to the audience one more time, should someone think of something after we sign off here.
All right, so my phone number is 414-322-8033. And that's 414-322-8033. My email address is info, I-N-F-O, at waltkeacademy.com. So it's waltkeacademy.com is W-A-L-T-K-E academy.com. So info at waltkeacademy.com. And I'd be happy to talk with you. And Jen, thank you so much for the opportunity to talk with everyone.
Absolutely. Thank you so much. And I hope everyone has a fantastic rest of their day.
Yeah, stay safe out there, everyone.